So hello, I'm very happy today to discuss the role of proton beam therapy in localized neuroblastomas. So I would like to start with some background thoughts. So as we all know, survival rates in high-risk neuroblastoma are increasing over time. And it was proven that local therapies are really impacting on survival rates. So therefore, reduction of adverse events is really very relevant today, but still we have oncological results to be further improved, at least for some of our risk groups. So with regard to the strategies, how to reduce adverse events after radiation therapy, the use of highly conformal radiotherapy techniques, of course, is one important measure to limit the risk of radiation. So in proton beam therapy, we have understood that the dose depth curve of protons is advantageous because we have a definite range and a sudden evolvement of the maximal energy and can spare very nicely the tissue distally to the target. That is also displayed here with one beam with photons, which is kind of canal traveling through the body, whereas protons stop and spare ionizing dose here distant from the target or distally from the target. And that, of course, is a major advantage. So by using proton beam therapy, we can achieve high conformality, but still we can limit the irradiated volume. And that's also what we see here at the left side. This is a proton plan, and this is an IOMRT plan. And you see very nicely that here the intestine, for example, is spared from ionizing dose, where here we spread medium to low dose volume. So we can, by using this aiming to reduce the risk for adverse events and secondary malignancy, we can, of course, also aim to improve quality of life after treatment. And we may need less compromises in order to sufficiently covering the target, but also spare sufficiently important organs at risk. We have the high demands of quality and radiotherapy in principle for neuroblastoma. We have demanding contouring. We have to find ways to have a good dose coverage of the target volume. We need to spare important organs, which are typically close to the target. And we have to deliver doses up to 36 gray for residual disease. And in addition, we have intensive systemic treatment, which may also impact on feasibility of the overall treatment. So therefore, old-fashioned techniques like here may not be sufficient to achieve our goals, and we need highly conformal, good radiation techniques. So when we look into the literature, it was understood quite early when comparing dose distributions from conventional photon therapy, IOMRT, or proton beam therapy, that proton therapy achieved substantial normal tissue sparing when compared with IOMRT. And that, of course, was very attractive for neuroblastoma. It was also understood that the sparing or the smaller irradiated volume with proton therapy was in models associated with a lower risk of radiation-induced secondary malignancies, which is also, of course, very important when looking at young children. It may be still surprising that when a group of experts met in Stockholm and we discussed for what entity proton therapy was preferred, for neuroblastoma, the majority still voted for using photons. And I think that is of surprise when we still all agreed that integral dose was lower for proton therapy. But I think there were some principal concerns, for example, also on financial and emotional burden for families to be relocated. Still, we agreed that in young children with curable tumor, delivery of moderate to high local doses in proximity to critical tissue, proton therapy would be preferred. And when we look at that list of criteria in neuroblastoma, we have young children, we have curable tumor, and we have the proximity to critical tissue. So one of the concerns, let's say the reasons to not give it priority at that time was that the dose when compared to other entities like CNS tumors, the dose was relatively low, using 20 to 40 gray, but not exceeding 50 gray as we have it in CNS tumors. So I think the relatively low dose led to the fact that we didn't prioritize at that time when proton slots were still limited, was accepted as a priority. And another reason was that there were concerns about robustness of proton plants in the light of motion or density uncertainties due to, for example, bowel gas, as our tumors are typically in the upper abdomen, and we have bowel gas interfering with the stability, let's say, of our dose plan. So here's one publication dealing with that issue and discussing that tumor location, target volume, and anterior extension of the PTV has to be taken into account when understanding if proton beam therapy is advantageous and feasible. Another publication from a Swiss group also looked into that and reported both on early clinical outcomes, but also on the techniques to mitigate uncertainties. And what they found is that in the early outcome of their patients, they had excellent results. They used rescanning of proton beam therapy in some patients, and they saw it was feasible and safe. And they also stated that, particularly in the sedated children, the motion they had observed were quite little, so that measures in sedated children may not be of the same relevance as for children being awake and fully conscious. So now, after those concerns, of course, and all the proton centers have reacted and implemented mitigation measures for geometrical or density changes. So many centers are using for DCTs, ITVs, or passive scattering technologies, gating. They take care about appropriate beam arrangement. They do robust planning. They do density override to calculate plans both on air-filled bowels, but also on water-filled bowels. They do rescanning, like shown in that publication, in order to have robust plans also in the area of the upper abdomen. So with regard to clinical experiences, we have some interesting clinical reports already on using proton beam therapy for neuroblastomas. And what is reassuring that despite the fact that some of them have not yet reached long follow-up times, still what they report so far is excellent local control rates. And when we compare this to results from large interdisciplinary trials, we are well on track. And I think we do not have any reason to believe that the mitigation measures we have for uncertainties and robustness are not sufficient, because then we would not expect to have satisfying local control rates. So one of those papers is the one from Hill-Kaiser, looking at 45 patients having a median follow-up time of nearly 4 years. And so 97% of the patients were free from primary site recurrence. They had very little acute toxicity, mainly grade 1, and on renal and or hepatic toxicity, they report no higher grade long-term toxicity, which of course is very nice. Another paper from our institution on 44 patients with mainly high-risk neuroblastoma displays similar findings. Higher grade acute toxicity was only seen for blood. There was one trans-ion myelitis after combined immunotherapy, but no long-term toxicity so far, but of course still a limited observation time. Here, I would also like to highlight that proton beam therapy was not only used for primary neuroblastomas, but also for recurrent neuroblastoma, again, displaying nice local control rates even after recurrences, and also was shown to be very feasible with no radiation-related nephro or hepatopathy after treatment. So also at our institution, we see an increasing number of patients. So end of last year, we had 83 patients treated with neuroblastoma. Today, we have already more than 100 patients. So the use of proton beam therapy also in Germany is really increasing. Majority of them having upper abdomen sites like displayed here. We also collect all information on adverse events prospectively on the patients, and we see that mainly, as also published, mainly side effects are seen for a blood system. What is also nice that with modern pencil beam scanning proton therapy, we can do intensity modulation being used for simultaneous integrated sparing, what we do routinely, and what we could also do are simultaneous integrated boost treatments. This is kind of one example for a neuroblastoma. However, within Europe, we have agreed that we don't use it in the upcoming SIOP in the new SIOP 2 trial. However, it could be done as we would do it maybe with IMRT. We also have to look, of course, at pattern of relapse and quality assurance and local control rates. So in Germany, we have a multi-center retrospective study ongoing to better understand how we use our instruments. So to conclude, I think we can state that proton therapy was understood to achieve superior dose distributions as compared to other external beam radiotherapy techniques with photons. However, we have to take care to have appropriate mitigation strategies to consider any potential uncertainty. The body of clinical data on proton beam therapy is growing and results are promising. It is therefore increasingly used for neuroblastomas, and I think it can today be considered as a standard instrument. I think we have to be all reminded that regardless of the technique we use, it is important in order to move forward that we collect data on second primary cancer, quality assurance, and also pattern of relapse to use our instruments of radiotherapy in the best manner. Thank you very much.